Hi everyone, and welcome to the fourth TIA Centre seminar of the academic year. So my name is Adam Shepherd, and I'm a researcher here at the TIA Centre. For those that are new to our seminars, we invite researchers and leaders in computational pathology and associated areas to discuss their work. I'm also now joined by Jachi, who's our co-host.
Yeah, hi everyone. I'm helping Adam with organizing the seminars starting recently.
And today it's an absolute pleasure to introduce Dr. Jana Lipkova. Jana is an assistant professor at the University of California at Irvine, with joint appointments in the School of Medicine, School of Biomedical Engineering, and the School of Computer Science. She completed her postdoctoral fellowship in the AI for Pathology group at Harvard Med School under the mentorship of Dr. Faisal Mahmood. Prior to that, she earned her PhD in computer-aided medical procedures from the Department of Radiology at the Technical University of Munich. And Jana now leads the Octopath Lab, which develops AI methods for diagnosis, prognosis, and treatment optimization in histopathology and beyond. And the title of Jana's talk today is Too Many Models, Too Few Benchmarks, Addressing the Benchmarking Crisis in AI for Pathology. So with that, I'll pass over to you, Jana, and we're looking forward to hearing your talk.
Hey everyone, thank you so much for the opportunity to be here and present. Feel free to jump in anytime. I would be very happy to get a feedback, question, discussion, and yeah, we can start. So first, why do we need benchmarks? So the idea of benchmark is to provide like a standardized way to evaluating AI models to have the same set of data, the same set of tasks, but also make sure everyone is using the same folds for cross-validation. We have the same performance matrices, and we define the reporting standards. So somehow standardize the way how we report the performance of the AI models. And the objective is to provide fair comparison of the model, but also identify weaknesses, strengths of the models, and to see how the field could be evolving, like what are the new types of methods we should be focusing, how we can grow together and make better outcomes. So that's for the developers, and for the user, your question is going to be like, which model should I be using out of all these possible options? So the benchmark should help you answer those questions. And there was recently this opinion published in the Nature Medicine that we have benchmarking crisis, which actually fit very well because we're already working on it. So I steal the title about the benchmarking crisis. But if you want to know more, I think it's very nice overview. You can have a look. And basically the objective is how we can work and learn together to accelerate the research. One important distinction is we have benchmarks and we have grand challenges. We probably saw some of them in pathology, like Chameleon, Chimera, Unicorn, and so on. And the difference is that the point of challenge is we want to identify the winner, like what is the best model for like limited amount of tasks, like maybe segmentation, detection. And these challenges are organized once per year. Data are private, and you have limited amount of space for experimentations because every time you want to test your model on the private data, you have to submit. So it's like always new submission. It's not that you're going to run 100 models because then your name is in the leaderboard. So maybe that can be, maybe you don't want that. So the challenges are more like a competition. On the other end, the benchmarks, they are used to evaluate and stress test the models under different conditions. This is why we have the different conditions. And it's not about the winning, but about how we can ensure reproducibility, robustness, best practice. And my vision for this benchmark is that they're going to be made on public data. So you can download the data, you can run hundreds of experiments to understand how your model is working, to see how you're comparing with respect to the other models. And also, if you develop a new model and now we want to know how we compare with the state of the art, you don't have to re-implement the other 100 models that were before you. You can just make the comparison using the benchmark. And of course, to some extent, it's based on honesty because the data are public. But then if you want to, I mean, of course, if you really want, you can cheat. But if you publish the data with where you cheat, you train on the test data, people will figure out. So this is going to be staying on your shirt, not anyone else. So it's like, this is just a tool for people to learn. Okay, but benchmarking challenges are basically complementary. So I just wanted to make the distinctions. And today I will be speaking about two of these benchmarks that we developed in my group. One is focusing on foundational models in oncology, and the other is about safe models and the guardrails for the AI in pathology as well. So coming to the foundational models, okay, this is the first one. So this slide is a bit old already. I tried to map the landscape of all the foundational models that we publish in pathology over a couple of years. And you can see like every few weeks now or a few months, we have new foundational models being published. It's larger, bigger, and so on. And each of them claim that it's superior to the previous models. And just things are getting a little bit out of proportion. This is just like to get impression if you would compare the number of slides that was used to train specific model. Python is our smallest foundational model, so if you would stack it, it would be as tall as giraffe. But if you go to the Virchow, it's like as tall as 4 pyramids of Eiffel Tower in Paris. So it's like, you know, things are a bit crazy. Now, if you try to develop your own foundational model, the question is, do I need more slides? How should I move on? Or if you are a user, you should be asking which one should I be using, right? Which is the most suitable for my application? And there already been few benchmarks, like most of them published this year, but we had a preprint a bit earlier. This is the one from the Gabriel Campanella, and this one is from Peter Niedlinger from the Jakob Kaiser group. And both of these benchmarks, they were very useful to understand the model designs. Like let me just show it off. So these different benchmarks, they look at a set of foundational models. Usually they look at binary classification, like a cancer detection or mutation prediction, but all these tests are performed on the private dataset. So it helps us understand like what are maybe some differences. But now if you develop new foundational model, you don't know how you compare with the previous models unless you implement everything. And it's like the field is going so quickly that the paper published, what is it, like in April 2025, the first one, it's already kind of outdated because now we have 50 other foundational models. So we would like to have this public source where people can apply the benchmarks. And another motivation was we don't really have a clean winner between the different foundational models as of now. And one opinion or one idea was like, maybe binary classification, it's not difficult enough for these models to really see the differences. So we developed, I'm jumping ahead. So this is one conclusion that we saw from this benchmark. We learned about the scaling laws, how the model, if the more slides not necessarily better with comparison to the having more patients or more anatomical sites was more beneficial. The larger models were not necessarily the better. So there was like, there are some conclusions for the user, like maybe you don't need to go and have a model with 8 million slides, but maybe better model design, more diversity is better. But again, there are these questions that I was mentioning as a user, which one you should be using. Maybe the binary classification is not even what you want to do in your model. Is it sufficient enough to compare these models? And there are a lot of things about generalization, interpretability. What about unimodal versus multimodal models, slide versus patch level models, and we don't have the public benchmarks. So we tried to answer all these questions in our study. First, our initial goal was actually to understand how the model compare, and then we decided, well, actually we can even share it with community and make it as a public benchmark. That's how the thoughts went. So this is the first benchmark that we developed, and we focus on survival prediction and oncology. And here the motivation is that oncology, the survival is much more difficult than binary classification. So maybe it allows us to better compare the different foundational models. But also in survival or any prognostic task, it's very difficult to build large cohorts where you have the patient information, like because you have to follow the patient across many years. So usually the prognostic models, we have smaller cohorts. The performance of the prognostic model is usually lower. So this is really the domain that would really benefit from this proposition of foundational models, that we can train more accurate models while having less training data. So this is what we try to understand in our benchmark. We are looking at a set of 13 different cancer types. We look at 10 different foundational models, and we have a mix of unimodal, multimodal, patch level, slide level models. We were very interested in generalization. So we train on data from one hospital, and we really stress test it on many different external cohorts to understand how the model generalizes, because that's something we don't usually study. And everything that we do, it's publicly available, although not only just the data sets, but also the splits, the evaluation pipelines. So the idea is like now, if you develop your new foundational model, you can just compare it with the previous models using our benchmark. And I tell you some conclusions that we learned and like what the different types of tests we did, and then hopefully it helps you motivate how you could use the benchmark for your study. So we're looking at two different formulations. One is both for survival prediction, but one is looking at the cancer-specific models. And here the idea is for each specific disease, you train separate model. Like at the training time, you take patients with the brain cancer, you train single model that predicts survival for brain cancer, and at inference time, you again take this one model that is specialized for the brain cancer and you apply it for the brain cancer patients. I mean, this is how would you approach in your standard way. But then we also look at something as a pan-cancer generalist model. And here we train single model across all the different cancer types, because the motivation came from the hallmarks of cancer. There are some features that all the cancer shares. So the question was like, can we learn prognostic features across the cancers and use it to generalize for the cancer predictions? So we train one model across all the cancer types, and then at the inference time, you can use the single model to make the predictions for all the different cancer types. So it's like, can we have a generalist model instead of having like 100 different models, one for each different disease? Can we somehow generalize? And we try to stress test all foundational models across these different perspectives. Now, one thing we have to define performance matrices, so like it's survival. So of course we are looking at the C-index for specific tasks, but also average across all the different cohorts. We look at the ranking score, like we look at the top 1, top 3 model overall ranking. We look at the percentual increase over the ResNet, like are we really gaining something with this foundational model? And the ones we spent most time was the generalization score. So we want to know how well the model generalized to different cohorts. So we're like kind of missing the measure to quantify. So we introduce one. We first look at the consistency score, which means, I'm telling it because I want to know your opinion, but our consistency score is like basically for each model and the cancer type, we compute how consistent the predictions are across different cohorts. But what happened, I thought it was a good measure, but what happened was that you can have a model that is consistently wrong. It's going to have high consistency score. So we tried to correct for it. We have this adjustment factor that compute like how well what is the average performance of the model for a specific cancer type. And we have this generalization score, which is a consistency, but adjusted by the performance score. So in this way, we just balance the model that have low C-index, but are consistently bad is gonna have lower generalization score versus the model that are really good and generalized bad is gonna have higher number. And the generalization score is a number between 0 and 1, but of course 1 would mean perfect performance, and I never had perfect performance with C-index, so it's more like a relative measure, so we can compare different models between each other. So this is just the numbers that we propose for the benchmark. And yeah, if you have a better idea for how we can quantify generalization, I would be happy to hear some opinions. And these are basically the results from our study. So I'm just picking a few. We look at the average C-index generalization score and the top 3 count, like how many times the model was among the top 3 across all 30 experiments that we did. And there are a few conclusions. So similar to previous studies, we saw that the larger models like a Virchow do not outperform the smaller models. In our study, actually, Conch was the best in all the different formulation. It has the best performance and best generalization score. We think it's maybe because of the large diversity that the model has for the training. We have more patients, more different data sets, but we don't know for sure. And then we look at the different types of model design. So one, we look at the difference between the cancer-specific and pan-cancer model to understand if our generalized approach is comparable. And actually, we saw that pan-cancer model is not inferior to the cancer-specific model, which is great because it means we can have a single model to replace all the individualized models, at least for now. In the terms of architecture, we were looking at the difference between slide level versus patch level models, and we saw that in our study, actually, patch level models outperform slide level models. And we think it's because these models have more flexibility to identify prognostic features. And I have one more slide about it because maybe we didn't expect it, but I have one more slide to show why I think that's the case. And the last, we look at the difference between unimodal versus multimodal foundational models, and we actually saw there was no benefit of having multimodal foundational models for survival predictions. I know that for different classification tasks this may be the case, but in general, for survival prediction, we didn't see the benefit. It's true that Conch, it's multimodal and it's our best performing model, but just being multimodal wasn't sufficient to be like the best model. And the reason here, at least in my opinion, is because the additional modality doesn't provide you any prognostic information. Like even in the Conch or any image text model, you have the image and you have the text that describe what is on the image, is like pathology report of the specific morphology, but it doesn't tell you anything about a patient's survival. So while multimodal foundational models are great for diagnostics, detection, we think that because there is no additional benefit for prognostic predictions, we didn't see this benefit with multimodal foundational model. Again, this is with we have like 4, I think, multimodal foundational model in our study. It doesn't mean that now new multimodal foundational model came out that's going to be better. This is just like with what we observe, and these are the ways how we can compare the different studies. I promise you justification about slide level versus patch level models. This is an image from the Tangle study, which is a multimodal foundational model that combine actually images with the transcriptomics data. And this is the attention heat maps that as it came from the Tangle model pre-training. So this is like, you can see the attention heat maps where the model is looking. Although at the end you end up with the slide level representation, the slide level representation is built based on this attention heat map. And what I also show in the study is like the model is looking mainly at the tumor region, which is really good for the cancer detection, but for the prognosis, I think this may be limiting because we are not looking at the tumor microenvironment. There may be many other structures in the tissue that may not necessarily be included in the single embedding. So that's why we think that patch level models were better for the survival predictions, because you have flexibility, and for each disease or the patients, the model can identify what seems to be more prognostic, not just the tumor, but also all the other structures around. Okay, and now interesting things with our cancer generalist model. So we have this pan-cancer model, and we said we can train we train one model across many different cancer types, and then we can apply the same model to make predictions on the different diseases. But it also means you can apply the model to cancers that the model never saw during the training. So we can start looking at the rare cancers or any out of distribution cases. So in these experiments, we train across 10 most common cancer types, and we apply to 4 rare cancers that were never part of the model training, meaning for the prognostic survival model. And we were looking at the bladder, ovarian, prostate, and rare lung cancer. So in our cohort, we have non-small cell lung cancer types, and as the outdoor distribution, we put a combination of different cancers that are different than non-small lung cancer, like a large cell lung cancer and so on. And here you can see the C-index performance by the ResNet model, which is around 0.5. It means that ResNet 50 is not really good generalized model, as you would expect. This is performance for the remaining model in the study. And we can see that, for instance, CONJ was actually the best model. I mean, it's not breathtaking, but bear with me. What is great about the CONJ, that actually in all cases, the performance was a little bit bigger than 0.5 in all cases. In some cases, it's like, very little, but at least there was some potential. Other models like Titan or GigaPass, they sometimes have better performance, but there were cases where the C-index was below 0.5, similar for the Titan. But what is really nice with the slide level foundational model is you have single embedding for the whole slide. So now instead of, when we train batch level models, we are kind of limited because we can use only batch size 1, which also limit which loss function we can use for our predictions. But with the slide level models now, we can have much larger batch size. You can try much more fancy loss function, and this is what we did in the study. So this is performance of the slide level foundational models with the different loss functions. And what we saw at the Titan model, oops, so this is summary of what I told you, but we saw the Titan model, which is the purple, actually has a really high performance across all 4 rare cancer types, despite that model never saw them during the training. So it's really nice to see that these models can actually generalize to cancers never seen during the training. And one hope, I think the CONJ was, when in our previous experiments, CONJ was better than Titan, but now as we get stronger GPUs, maybe we would be also able to try to train patch level models with larger batch size in the future. So I think there is a potential of having this pan-cancer generalist model, and that opens some possibilities for the rare cancer types. And of course, you can always take this model and refine it with your rare cancer samples, but just to see how the model perform on the auto distribution cases. And the next things we looked was interpretability. And this is so here you can see interpretability for the lung squamous cell carcinoma, and in the first column is performance with the cancer-specific model, and in the second one is the pan-cancer generalist model. And we have attention heat maps only for the patch level models. We don't really have interpretability for the slide level models, which is something you may want to consider. And what you can see is that the heat maps are not the same. Different models, in principle, looking at the different regions. We saw some yes, I mean, if you're optimist, you can say, oh, that's great. The model look at the complementary information. Maybe if we combine it together, we can learn something better. But also you have to be very careful if you want to use these heat maps to make biomarker discovery, because now it means different model you pick, you may get a different high attention region. Also, we need to mention that for survival prediction, the attention heat maps are a bit different in interpretation than for the cancer detection. With cancer detection, it's very clear. The model is looking at the tumor, yes or no. With the cancer, with the survival, we know that this was important regions, but we don't know if it was necessarily related with increasing or decreasing the risk of mortality. But anyway, just to be careful not to overinterpret the heat maps. And there were some similarities that we saw that image-only model, for instance, Uni and Virchow, if we had cancer-specific model, it was looking actually at the tumor region in both cases. while the multimodal models like the cancer-specific model was looking at the tumor regions, but the cancer-specific model was actually looking at the tumor microenvironment. I cannot use my mouse, but the conj is the first in the top. So the cancer-specific model is actually looking at the tumor microenvironment, while cancer-specific model is looking at the tumor microenvironment, while cancer generalist model is looking at the tumor region. So it's like probably because of the generalist model, it was more helpful to try to understand different tumor morphologies, while with the cancer-specific model, if the model was trained only on the lung cancer cases all the time, then maybe the tumor itself alone wasn't so predictive and the tumor microenvironment started to be important. What is nice is we can also look at the generalization and the heat maps on these rare cancers that were not part of the model training. So these are both columns are made with the cancer generalist model, and these are type of lung cancer that the model never saw during the training. And it's really cool to see that models like Conj mainly is focusing on the cancer morphology of specific disease, even though it never saw those cancers. So there is some like potential. To kind of one more type of interpretability is you can look at the UMAPs, and so here you can see the distribution of the UMAP from the different models. And if you color it by the different cancer types, you can see like some of the models like Titan Conch, they're really good at separating the different type of diseases. The problem is now if you look at the same heat map, this UMAP, but you color it by the survival risk, we see that there is not really much difference between the ResNet and the other cancers. So what we saw from our benchmark is that survival is very difficult, and the existing foundational models, they are not yet optimized for the survival prediction. So this is kind of a brief summary, and hopefully it's going to motivate you. So we saw that, yes, we have these foundational models for the survival prediction. We build the benchmark. We look at a different cancer generalization to different diseases, generalization to out of distribution cancers, like potential for maybe zero-shot survival prediction for rare cancers. But what we saw is there is still space for improvement. So maybe you can try to looking at developing your own foundational models optimized for the survival predictions, and then you can use our benchmark to compare with the state-of-the-art methods. And yeah, this is how our benchmark came up. I think there were some comments, or you can take a break before if there was a question before I go to the next one. We are exactly in the half.
Sure, thanks, Jana. I think there's a question from Ether in our group who said, given the fact that cancer types are inherently different in terms of mean survival time, how do you know whether the generalist model is actually learning common features across cancers or just learning to differentiate between cancer types?
We don't. No, but I mean, for some cases, the performance of the cancer generalist model was higher than performance of the cancer-specific model. So I think in this case, it implies it's learning also within the cancer type. Because we don't really know where the model is looking, right? What are the prognostic regions? So it can be that it's just looking at features that are common across different diseases, like the tumor infiltrating lymphocytes, trauma, and then like maybe difference normal versus the cancer tissue. But we don't know the differences. But the fact that the generalist model outperformed the cancer-specific model, it's actually interesting. So there's probably something, but I don't know how much, right?
Sure, thank you. Does that answer your question? Yeah, perfect. Do you have any more questions? I think we've got a couple more questions. We've got one from Ahmed online who said, the differences are foundation model performance. Could it be stemming from the different strategies of training, like using specific augmentation methods or optimizers approaches, or is it solely based on the diversity of the data trained on?
So in our benchmark, all models were trained in the same way. So we extract features from all foundational models and we train the model exactly the same pipeline. So there's probably not much about augmentation, or at least this part is fixed. Of course, each different foundational model was trained on different data, different set of patients, and there is many stuff that we don't know how these models were trained. So it's like now we are using this benchmark to reverse engineer what is working, what is not. But yes, of course, the different way how the foundational models were trained matters. So what we saw is a different data diversity, like in the Conch matter more than the number of slides. Like if you compare Conch versus Virpo, which there is like almost 100,000 versus 1 million slides. So I'm not sure actually if I answered your question. Summarize.
No, that's brilliant, thank you. And just had another question as well from Jack online who said, should we conclude from the relatively limited C-index scores that it isn't worth doing survival prediction from histology alone.
Fair enough. I think in general, there is a limit on what we can predict in terms of survival from histology images, right? Because we are taking the histology slides from the diagnostic time, and then the patient has a treatment, and a lot of many things happen on his patient journey till we reach the survival, and we're trying to make the prediction from the initial H&E slide. So there is certain limit on how much information we can get from there. But for some cancers, for instance, we can reach the index like 0.7, 0.8, while for others it's still 0.5. So maybe there is a way to push the boundaries and make a better prediction. And then maybe survival is just one of the prognostic endpoints, but you can be looking treatment response or something in close future. So it's gonna be maybe more robust. Yeah, we just have access to survival information. That's why we use them. But no, don't give up on survival. Okay.
Brilliant, thank you.
Thank you, very good. So we had nice commercial break, and then the second benchmark is about auto distribution data detection. Okay, the first the motivation is we have all these awesome foundational models or all awesome AI models in AI, maybe not for survival, but in general, for cancer detection or subtyping, we already have AI models whose performance is matching humans. And we have this new emerging AI that try to predict mutation from H&E. There is a lot of potential for this AI. So now we can start looking at translating this model to the clinical settings, which came with the questions about the safety. And one of the challenges is that many of the models are developed under so-called closed-world assumption. And it means that we assume that the data the model saw during the training, it's going to be very similar to the model is going to meet at the inference time, which kind of is good. But in the reality, in the clinical setting, this is not the case. It's more like this, right? There are going to be a lot of irregularities, anomalies, like variation in the data preparation. There can be human errors, different domain shifts. And our models are not robust enough to capture these differences. So it's something that we just have to, once you start thinking about model deployment, these are the questions you have to be asking yourself. Just maybe to illustrate it on the example. So let's say you develop a model that's gonna do lung cancer subtyping to differentiate lung adenocarcinoma from lung squamous cell carcinoma, because these are the two most common cancer types. So maybe you want to develop AI that's going to automatize detection and classification of these cancers in the clinic. Maybe 70% of the lung cancers are going to be one of these two, so you can reduce the workload. The problem of this closed assumption is if you present the model with any of this data, it will still have to assign a label of lung adenocarcinoma or lung squamous cell carcinoma, even though it may not be necessarily meaningful. And you might be thinking, okay, this is simple binary classification. But now as we move to the agent-based AI models, where you have many different models that perform one task, which can be very specialized, and then you have the orchestrating model that just organize all the different models. In this case, it's going to be very easy for the errors to propagate through the system and very difficult to backtrace those errors. So we have to start thinking about the different guardrails, how to protect the model performance. And it reminds me of this cartoon. I don't know if you saw it, but
it's not. What? Is that a dog or dog, pig, dog, pig, dog, pig, pig, loaf of bread, system error?
So in principle, we don't have system error, but the fact that the model cannot abstain from the prediction when it doesn't understand the inputs can lead to the errors in the medical and the medicine, which can impact patient. It can reduce the clinician trust in the AI models, and it can also reduce the clinical utility of the AI models. So it's we would like the models to make correct predictions when they are sure and abstain when they don't understand the data. So this is something how it's gonna look like. We have these safeguards. You have your standard pipeline, but now you introduce this guardrail. It's before you make any predictions, you want to check if your input data belong to the distribution the model is familiar with, or if the data doesn't belong to your distribution, you should abstain from the predictions. So again, you want the model that make predictions, provide reliable predictions if the data fail in its domain of expertise, and abstain otherwise. So for instance, in the example of predicting mutation from H&E slide, it's okay if the model cannot make the predictions for all the patients, but if we can identify 80% of patients for which we can have predictions with 90% accuracy, this is fantastic. And then we abstain from those cases where the model is not sure about the predictions. And this can be many different things. It can be maybe that it encounters rare disease and the model doesn't know what it is. So maybe you can bring the sample to the tumor board, you want to speak with the doctor or with the human expert, maybe you want to add a special stain, maybe the quality of the data is not okay. So there are many different things that may be out of distribution. And this out of distribution detection is not a new term, it's very common in the computer vision. And in principle, you can think about it as a binary classification where you try to distinguish in distribution versus out of distribution samples. So in distributions are those the model was trained, out of distribution is everything else. The problem is that to train these models, this binary classification, you have access only to in-distribution samples. So it's not so simple. We cannot build the data set of all possible out-of-distribution cases. Maybe these are rare diseases and we don't have enough large cohorts to build the out-of-distribution cases. Or in reality, we just cannot imagine what all the possible out-of-distribution cases can be. So you only have access to in-distribution data, and now we have to understand how to differentiate it from the out-of-distribution. And again, this is not a new idea. This is what your smartphone is doing when you try to unlock it with your Face ID. Your phone doesn't know all possible faces in the world, at least hopefully. It just knows how your face look like under different conditions, maybe you before or after coffee or, stuff. And then it knows when it's you and it learns when it's not you. So the model has to learn characteristic of the data that belong to distribution and flag all the cases that deviate from the distribution. And as I mentioned, this is not new in computer vision, but we realized that the formulation in computer vision doesn't generalize to the pathology. And to convince you, I show you a few examples of the outer distribution ideas that are normally used in general computer vision. So they look at the different type of domain shift. One of them is covariate shift. And for instance, the idea is that you have images from your in-distribution that were like, for instance, cipher 10, and out of distribution data are the same images, but you have different brightness, contrast, noise. Now if you ever work in pathology, you're like, no, we want our models to generalize to the diseases, to the scans with the different noise, with different image quality, while in the standard computer vision, the objective is to differentiate these in distributions are data from this one scanner, and everything else with different variation noise should be out of distribution. And another example is a semantic shift. Okay, this makes sense in computer vision because your in-distribution data are, for instance, CT scans, and out of distribution is a completely new category of the images. And what people do, sometimes they look at natural images, pictures of cats and dogs versus CT scan, which again makes sense from the OLD detection point, doesn't make sense from the clinical perspective. And another one is acquisition shift. Again, in standard computer vision, like if you acquire the images with two different cameras, you want the model to be able to differentiate it. Again, for us from pathology, this is like, you're like, no, our model have to be able to generalize. And another one is the contextual shift. Okay, I just list this. But these are examples from some of the benchmarks. So for instance, your training data can be handwritten digits or number from 1 to 10. And then your distribution, like OD, can be very different images, like for instance, the letters, the fashion images, cipher 10. Like you see the difference is really large if you go from the digits to pictures of images, pictures of fish and places. And recently, like earlier this year, there was published this, it's actually a benchmark for OD detection in medicine, but they try to answer many questions at once. And it's like in distribution data can be MRI scans, and out of distributions are CT scans. And you can even have far OD, which in distribution is brain, out of distribution is like abdominal scans. Then there is a different surgery. When you have surgery, I think the first one was colon, and then can see the surgery, we receive the piece of eye. So it's like very different. I cannot actually judge the surgery, but looking at the histopathology data, this is very tricky. So in distribution would be small, tiny regions of that shows you the cells with mitosis, and then you have different types of cells that's going to be out of distribution. But we know in pathology, we rarely make predictions on the patches, like on these tiny regions. This is like 50 times 50 pixels. We don't make predictions on the whole slide images, and under this formulation, multiple patches from the same image, from the same whole slide image can belong to in distribution and out of distribution at the same time. So again, I think these all make a lot of sense for computer vision, but it's not so suitable for histopathology. And because we want our models to generalize across different scanners, population, noise levels, we would like, the images are huge, and you can have different tissue constituents like lymphocytes that are present both within and out of distribution data. We have large variability into diseases, like you can have different grays, different infiltrated tumors, and you want to work on the whole slide image. So this is just to motivate you that maybe we need some other benchmark that is specific for histopathology. And this is what we try to do. We try to develop detection or OD detection benchmark specific for histopathology. We try to redefine the taxonomy to make sense in the histology, but the example or what is the benchmark is doing, our in-distribution task is very simple binary classification of the non-small cell lung cancer in lung adenocarcinoma versus squamous cell carcinoma, and we're looking at the whole slide images. And we develop different type of domain shifts that are specific for histology, at least what we think. And I will show you more, and then basically what's the benchmark doing. And for all the domain shifts, we generate and we provide the data. So first, what are the different type of domain shifts? Like rather than looking at the images of the H&E and pictures of cats, we try to do something more meaningful. And these are the different type of domain shifts with different type of difficulties. So one domain shift is like, imagine you have different anatomy and different pathology. So what it means, you're gonna train on your in-distributions are whole slide images of the non-small cell lung cancer, and now you get as an input image of the brain cancer. So this is very kind of easy. The model should be able to differentiate it. This is different disease. This is different anatomy. This is gonna be my in versus outer distribution case. The more difficult case, you're gonna have same anatomy but different malignancies. We call it neoplastic intra-organ shift. So here you again trying to detect the most common lung cancer types, and now we're presented with a case of rare lung cancer types like small cell lung cancer. Again, your model never see this type of cancer, but it should be able to differentiate it. But it's more difficult than the previous case because now both samples came from the lung tissue. So you're gonna have healthy lung tissue, but the disease is gonna be a bit different. In other cases, we have, again, lung tissue, but we have non-malignant mimickers of the cancer. Here, what we mean, they're going to be different reactive or inflammatory tissue presented in non-cancer tissue that, however, can be present in both in cancer versus non-cancer, like inflammation, fibrosis, edema. And again, it's like the model has to be able to differentiate it between these two cases. Again, I'm not saying that the differentiating lung adenocarcinoma versus squamous cell carcinoma is the world's best model, but it allows us to stress test these outer distribution methods under different approaches. Another domain shift is like differentiating lung tissue with the cancers versus if you have healthy non-cancer conditions that are not that similar to the cancers in the previous case, like we have some pigmentation calcification. So this is the first set of the domain shifts. Another domain shift that we have is we have different organ, but we have same pathology. And I don't know, now it's going to be down to the biology, but you can have in distribution is lung adenocarcinoma, and outer distribution is gonna be colon adenocarcinoma. So it's like this is actually very difficult also for all the models because the cancer types look very similar, but the healthy tissue it's a little bit different. But usually we don't have that much of healthy tissue in the whole slide image. And then we have similar case where we have squamous cell carcinoma. So in distribution is gonna be again lung adenoid and squamous carcinoma, but we have head and neck squamous cell carcinoma and other types of squamous cell cancer. And then this one is kind of easy. We're gonna have different types of stain. We were just wanted to know which model performed well. We have H&E versus IHC stain. This is a question for the audience. I initially wanted to include lung metastases, but we couldn't decide if they should be in or out of distribution. Imagine you have a case where the breast adenocarcinoma spread to the lung. So you're gonna have adenocarcinoma cancer in the lung, and I just didn't know if it should be marked as in distribution versus out of distribution. So for now, we don't have metastasis in the benchmark, but we are considering to figure it out. And the last two experiments belong to the quality, to the shifts in the quality. So one is like when the images are getting more blurry or noisy. You can imagine maybe in a hospital, you have a scanner and something is gonna get offsetted in the scanner configuration, and over time the images get more blurry and blurry. So you would like this outer distribution method to capture when the quality of images drops, and the doctors are like, and we are not able to make a correct prediction. And the last one, we are looking at the adversarial attacks, where we have our input images, we provide some attack, and now instead of thinking the models, if we provide a sample of the lung adenocarcinoma after the attack, the model is going to think that this is a glioblastoma. And we have two types of attack, one that work on the patches and one work on the features. So we introduce all these different domain shifts. And the motivation, the objective of the benchmark is try to figure out which methods perform well on which conditions, where do we need to improve all the methods, where is the space for limitation. And in our benchmark, we actually implemented 40 state-of-the-art standard audit detection methods from the computer vision, and we provide code and implementation. We just adjust the methods to work with the whole slide images, either with the conch or Titan features. And we were looking also at the way how the models generalize, like between the different cohorts, between different data sets. And as before, all the data, all the splits, all the adversarial attacks are going to be part of the benchmark. And I'm not going to present you the results because we did like it's over 3,000 experiments, and I still have to organize it to provide some insights. But a high-level overview is that actually I have it here. This is the benchmark, and hopefully we're going to get it out by end of the year. And there were some observations that there is no single best audit method that's going to work for all the methods. There are some domain shifts that are more difficult than the others, like for instance detecting the colon adenocarcinoma, distinguishing it from the lung adenocarcinoma was very difficult for the models. There are rare lung cancers in the lung tissue was very difficult. Adversarial attacks, it's a mixed bag. Different models perform differently, but we didn't find anything that was very stable. But we have very good adversarial attack method on the bright side. But none of the existing audit detection methods is specific for the pathologies. I think there is a lot of space to develop audit detection methods that are specialized for the histopathology data, and we expect to see better performance. And hopefully this benchmark, like as I said, we're going to publish it once we wrap it up. And hopefully it's going to inspire more people to start looking at developing safe models or improving the safety of AI in pathology. And with this, I want to thank everyone, and I want to mention we have open position for a postdoc student. And with that, that's end from my side. So if you have any questions, you can do that.
Fantastic. Thank you very much, Jana, for a really, really interesting talk there. And so, yeah, with that, we'll open the floor to questions. So does anyone online or in person have any questions for Jana?
I have a question. Would you be using the benchmark, guys? Interesting.
Yeah, I think it's a really important thing to introduce. We're seeing so many different models that are coming out now. So yeah, definitely. And I really also like this idea of guardrails too. Yeah, definitely. So in terms of, so do you have any questions for anyone in the lab then for Jana? Has everyone already asked their questions? Chachi, I think, asked a question online. He said, pathology foundation models are trained on millions of patches, but very little metadata. Do you think the next wave of breakthroughs will come more from better model architectures or better dataset curation or training?
That's a good question. I don't know if better data curation, because like Virchow, the Virchow 2, I think they have 3 million of images. So probably we don't need more data. I don't know where they store it. Now this is going to be 8 Eiffel Towers if you stack it, right? But probably I think we need new type of methods. Like we don't have anything that is related to prognostic predictions. Like maybe there is just so much we can do through self-supervised learning. Maybe if we inject a little bit of like not a weak supervision in terms of the pathology data, but a partial supervision, maybe we can try to refine, or if there's a way to, I think the multimodal data fusion in foundational models has a lot of potential, but especially for the prognostic predictions, if we can fuse it with some prognostic information that may again help with the prediction. So I think we need new types of methods and maybe slightly different types of supervision.
Sure. Does that answer your question, Jachi? Yeah. Brilliant. Thank you. And we've also got a question online from Patrick, who said, regarding your question of, for example, breast cancer metastasis should be included, depends on your definition of distribution. So formulate as a question, what is your definition of distribution here?
So for us, the in-distribution data are going to be lung adenocarcinoma and lung squamous cell carcinoma, but we always look at the primary cancers. But I'm just afraid that from the histopathology representation, if you have adenocarcinoma that's spread from the breast to the lung, we may not be able, so pathologists tell us they cannot differentiate it. And I don't know if the models can differentiate it. And it's hard to say. Because it's hard to say if you should penalize the model or not for these predictions. But we are trying to collect more metastatic cases and see if we can include it to the benchmark, which is another reason why things go a bit slower, waiting for some approvals. So for everything that we are publishing, this is combination of public data. But for some of these things like the metastasis, we're also looking at the COVID cases that we try to add because we think it's going to be interesting. but we need to wait for the approval to see if they can be part of the benchmark.
Sure, thank you. And I was also thinking about in terms of what you said for looking at heat maps for prognosis, especially when using these sort of foundation models. What are your thoughts in terms of interpretability with foundation models then when we go towards this prognostication task? Because of course interpretability is really important for clinical adoption, etc. So if we can't trust a lot of the heat maps or we can't interpret them in certain ways, which is true, how do you envisage us gaining more interpretability with these sort of models?
Yeah, I think it's very, very tricky, right? Because I think with this, the problem was there was another benchmark from the Jakob Kara group, and they saw the different foundational models for cancer detection tasks. They were actually looking at different tissue regions, and they start to, they make you question stuff. I think my slide just freeze. So I think there are differences between foundational but already for simple tasks as a cancer detection, which is kind of tricky, maybe just because different foundational models are maybe not good enough. Maybe you want to look at some consistency across the same disease from multiple patients. For the survival prediction, it's very tricky. So we try to look at the data with pathologies and the regions that the model considered to be highly prognostic. Usually it's not a healthy tissue. There is always something. There are some like tumor infiltration in the surrounding tissue, or there are some like signatures that seems to be irrelevant. But the problem is like, I think a nice example is when you have this cancer-specific model, like every single model sees is the same type of cancer. And so at this point, maybe just looking at the tumor alone, it's not so discriminative as looking at tumor microenvironment, which is good because it helped the model to explore and find like a prognostic features. But it doesn't mean if you want to now discover biomarkers that you should not look at the tumor region. So it's like, yeah, I don't have a correct answer. Just like we have to be very careful, like what are you trying to do, what you're trying to interpret, and yeah, it's hard. I think maybe we also need different type of interpretation for the prognostic predictions because we don't want to know only where the model is looking, but why, like, is this really increasing or decreasing the prediction? Something like SHAP, but it's very hard to scale for the whole slide, but something along that way.
No, brilliant. No, thank you very much. So if we don't have any more questions from people online or in person, then I suppose we'll draw our seminar to a close. But just a quick reminder for everyone, we do have another seminar this week, actually on Friday. We have a Friday on 21st from 11 to 12. We have a talk by Professor Jinte Kwak from Korea University, where he's going to discuss his work on pathology knowledge-guided AI models in CPath. So I hope to see you all there, but thanks again, Jana, for a really, really interesting talk.
Thank you. It's great to be here. Thank you.
And yeah, thank you everyone online as well and in person. Thank you. See ya.